Thank you so much. A lot of discussion in this instruction course is going to involve using medications. I'd like to just say that we don't have any specific financial interest with any product. And we've tried to give you initially a little bit about the diagnosis, but of course, in your clinic, you will find a whole variation of patients. And sometimes, as the previous speakers have said, you're really not sure, is it the dryness, is it the infection, and which is the cause and which is the effect. And hopefully at the end of this course, you'll have some kind of a systematic thinking and go step by step in how to handle such patients. Now, talking about hyperosmolarity and osmoprotection. So these are words everybody is already familiar with and everybody has read a lot and already knows about it. So why should we have this, this discussion? It's just basic to see that is it just something that is totally theoretical? Is it really just a myth that we've been told, and does it actually happen in practice? The world is changing. There's a changing climate, not only around us, but also in our own lives. There's change in the environment, there's a lot of pollution, and there's also lifestyle changes. And how is the tear film exposed to this? It is a complex ecosystem, and though it's very much inside the body, but it does engage a lot with the environment. You'll be surprised to know how day-to-day activities can affect the tear film. There is a very delicate balance. It's a very small ecosystem, but it's very, very tuned. And then there could be inflammation, which could be local and systemic. And what are the new frontiers, as both in terms of diagnosis and therapy, and what is the industrial impact, not only in terms of occupational disorders, but also what is the industry providing us in handling such patients. So knowledge is, of course, an easy solution, but the knowledge sometimes is confusing. You don't know what to balance, what particular approach to take. But you have to have a little basic rationale for the etiopathogenesis, because that gives your mind some kind of thinking or some kind of logical approach to the patient. And also, the etiopathogenesis should encourage us to do modes for prevention. That's something that we can work for, not only for our patients, but also in our own lives, because we also as doctors are exposed to all the diseases that our patients can get. Drug discovery, targeted therapy, and a healthy lifestyle, diet, and other preventive measures. So as far as the pathophysiology is concerned, there are certain aspects which are unclear, certain suggestive, certain which are mostly consistent, and over the previous talks, we've learned what are the big bugbears or the usual culprits in causing dry eye. And then they lead to this kind of deficiency, which is, as you know, aqueous or evaporative, but ultimately you have a decrease in tear film volume. And as a result of that, you get a hyperosmolarity, and this is regarded as a central mechanism. And it not only it's just the hyperosmolarity per se, but it triggers a whole set of mechanisms on the ocular surface as a cascade of inflammatory events. So as I said before, is it the dry eye leading to the inflammation? Is it the inflammation leading to the dry eye? And the answer is both. And it's the history and your approach to the patient which will help you identify which came first and which is escalating or exacerbating the other. There is an activation of matrix proteinases and various signaling pathways with the generation of inflammatory cytokines, and it is important to bear this in mind because when you're seeing a patient with a dry eye, you are deciding whether to put a punctal plug. Bear in mind that if there are a lot of inflammatory cytokines on the surface and you plug the drainage, then those cytokines are going to remain on the surface for longer. And these inflammatory events lead to apoptotic death of the surface epithelial cells that we knew, but also the goblet cells. So we used to think that aqueous deficient dry eye, mucin deficient dry eye, and evaporative dry eye. But even these kind of dry eyes can lead to mucin deficiency as well. And some of the agents that we have now can take care of this. There is a tear film instability. It is seen in patients with evaporative dry eye, and it is triggered by meibomian gland dysfunction. And it can also be the initiative event in post-LASIK surgery, vitamin A deficiency, allergic conjunctivitis, topical preservative use, and contact lens wear. And the last two I would like to highlight, because we may be prescribing contact lenses for patients. We may be using drugs for, as I attended the previous session on uveitis, and they were talking about about putting the steroids every minute for 5 minutes, and then every 15 minutes for 2 hours, and then every hour for 3 days. So you can imagine the whole load of preservatives in such patients. And and also glaucoma patients who are on chronic use. So therefore, these are the situations that we need to be alert for. And even after cataract surgery, you can have dry eye precipitated. So just to explain, we have this inflammatory cocktail which is floating around in the tear fluid. It's a toxic tear fluid which is decreased quantity, which is decreased quality, and delayed clearance and increased residence time. So we need to keep this all in mind. Now with the DUES 2, 10 years after the previous DUES of 2007, we have now the DUES 2. The objective one was to create evidence-based definition and a contemporary classification. Central concept has been recognized as loss of homeostasis of the tear film. Looking at the previous history, there was initially the definition 1995, then 2006 the Delphi Consensus Group, and 2007. So over the last 10 years it has taken to come now to the effect of 2017. It is a little simplified. It has addressed the multifactorial nature. The role of inflammation and hyperosmolarity is now ingrained in the definition, showing that the knowledge is more and it is more strong. It also has included expected outcomes as well as etiology. It also included symptoms. Symptoms plays an important role, and the role of neurosensory abnormality, as you realize in some of the masquerade syndromes. So this is the definition, and the objective 2 also assess the etiology, mechanism, distribution and impact, and also address the management and therapy. So there is this very nice cartoon which tells you how to approach the patient, and I would like to highlight here through my talks few aspects of this. So you have a patient who is presenting, and how will you approach the patient? You will see whether the patient is asymptomatic and symptomatic. Now what about the asymptomatic patient? This is important if the patient is going for cataract surgery, if there's a glaucoma patient whom you're going to put on medication. So these are the ones whom you must also look carefully on the slit lamp to see if you're going to precipitate a problem by your therapy. And then you would see whether the patient has signs without symptoms, and whether the patient has a neurotrophic condition or a dysfunctional sensation where actually there are, the patient is asymptomatic but there are signs. So maybe the patient has a hepatic eye disease or a sensory problem with the fifth nerve. Symptomatic patients, again, you will see what are the signs, what are the symptoms. There are triaging questions which I shall go over further. And if there are no signs, then you have to look whether it could be a case of neuropathic pain. And then the dry eye disease, that's not mutually exclusive. As we explained before, you could have a combination of aqueous and evaporative, and as I told you, even mucin deficiency can result as a consequence. So now what about the tear film osmolarity? Several people who may have actually used this diagnostic kit may be a little disappointed to find that the values vary too much, and you cannot always titrate your treatment based on that. But that itself is intrinsic to the disease. So you may have repeated measurements and you may have variability, and it is that variability which is in fact supportive of the dry eye state. So normal subjects will have a low osmolarity or a normal osmolarity, which will be relatively stable every time you check it. Whereas heteroscoscedasticity is an increasing variation with an increasing value of the hyperosmolarity, indicating a dry eye state. The other thing is between eye differences. So you may have the value below 308, but the difference between the two eyes may be more than 8 milliosmoles per liter. This is also considered as an indication of loss of tear film homeostasis and occurs with dry eye disease. Now the triaging questions is what you will do. You have a systematic approach, not do the whole battery of tests on everybody. To a risk factor analysis, don't forget to ask about smoking, contact lens use and chronic medications. And then you have the symptomatology. You can either use the DEQ5 or OSDI, and if it's more than equal to 6 or 13, it's abnormal. And then you can do one of the additional tests, either a non-invasive TBOT, which would be less than 10 seconds. You can do the osmolarity, and you can do ocular surface staining. In case a non-invasive TBOT is not available, you can do the fluorescein test, but that is recommended to go in sequence as after the osmolarity. So if you are going to use fluorescein to do the TBOT and you want to do an osmolarity as well, you will do the osmolarity first. Okay, so that comes to tear osmolarity. The cells require stable osmotic environment. The use of tear osmolarity in the diagnosis, you'll fortify. A whole lot of articles have been published, and osmolarity generally increases with the disease severity. As I said once before, non-invasive BUT can be done. These are your triaging questions. It's there in the publication, which you can look up: how severe, how long, any other symptoms, and the cutoff values will take 308, and it's found to be fairly valuable in identifying mild to moderate and severe dry eye if it's more than 336. Now, just a few slides on the treatment of this hyperosmolarity, and what about using osmoprotectants, the role of compatible solutes. Now, as I explained, when you have hyperosmolarity, the cells get dehydrated, there is a degranulation within the cells and a production of inflammatory kines. If you're able to bypass them by hydrating the cells without affecting the cellular metabolism, that is the key, and that can be achieved by certain agents called compatible solutes. What are they? Carnitine, glycerine, and erythritol, and trehalose. These are examples. And pro-inflammatory markers and an innate inflammation in dry eye disease has confirmed the help of such agents in controlling the inflammation and increasing the tear film's instability. However, there's a whole plethora of agents available in the market, and it depends upon the study that you're looking at. Generally, you would work on tear osmolarity has led to a better understanding. It is as far as tear osmolarity, you can say it's a useful, non-essential tool, and osmoprotectants usage is to be encouraged in cases of dry eye.